Well, welcome to all the participants in this International AIDS Society Educational Fund workshop. This has been organized in collaboration with the Desmond Tutu Health Foundation. And as you see, our theme is the last mile, the longest mile, realizing the promise of an AIDS-free world. And it's here in Southern Africa that we are conducting this virtual workshop. My name is Linda Gale Becker. I am the Chief Research Officer of the Desmond Tutu Health Foundation, and it is my pleasure to be co-organizing this meeting with colleagues from the International AIDS Society, and particularly the International AIDS Society Educational Fund. I want to tell you a little bit about the RIAS Educational Fund because I think it's important. Our organization, the RIAS, is a members-based organization, as you well know, the largest stakeholder members organization in the world. And a number of years ago, in keeping with our theme of people, science, progress, it was recognized that we needed to go beyond our convenings, those very important conferences that are held in various parts of the world at various times during the year, that we needed to become somewhat regional and bring those learnings to our members, to people where they are at. In other words, help towards implementing the science that we transmit so well at our conferences to actually see them become policy and plans in the field. And today's workshop is one such very important workshop. It will be discussing the main challenges and the recent updates on the HIV response in Southern Africa. And today and tomorrow we'll cover four main topics. So the topics we've chosen, and we hope that you like the approach we've taken, which is a game frame kind of upbeat approach. The first is PrEP, taking the anxiety out of sex. In other words, how do we actually make prevention something that people will adopt and roll out and scale up? Secondly, together with our colleagues at the CIPHER initiative in the International AIDS Society, we will be looking at embodying responsive clinical care to improve developmental outcomes of infants and children affected by HIV. So that'll be later today. Tomorrow, we will cover Children's Lives Matter. When did we stop caring? And that's a very provocative title that we hope will get all of you very interested to know more and engaged. And then lastly, a very important topic, is there any health without mental health? And in particular, is there any HIV health without mental health? And so we hope that you will embrace what we hope will become much more than just a sharing of information, but actually constructively move us towards co-creating solutions towards realizing that last mile. The movement towards actually achieving an AIDS-free world. And I hope that you will like the format of this meeting. We've purposefully kept it small. We've chosen the individuals who've been invited. So at this point, you should congratulate yourself for being on the invitee list. Because we really do want individuals who we know are going to engage constructively to help us co-create solutions and help us realize the next steps that are needed. As the workshop unfolds, you will recognize and be drawn in to how interactive we are hoping this workshop will be. And that's all from me. It is now my pleasure to hand over to today's facilitator, a very good friend, Professor Kenneth Ngura. He is an Associate Professor of Global Health and the Chair of the Department of Community Health and Chair of the Ethical Review Committee of Jomo Kenyatta University of Agriculture and Technology in Kenya. He is also an Affiliate Associate Professor in the Department of Global Health, University of Washington, and affiliated to the Institute of Tropical Medicine and Infectious Disease of the Kenya Medical Research Institute, as well as a visiting scientist at Kenyatta National Hospital. And as if that shouldn't keep him busy, he is also our representative on the Governing Council at the International AIDS Society, a long-serving member, a member of the executive, and a critical scientist here in this region. At this point, it is my great pleasure to hand over to Nguri. Over to you. Thank you.
Thank you, Professor Rida Gale, for the kind introduction. Greetings, everyone. It's good to have you here today. Before we get started for this session, let's take a moment to commemorate two leading HIV scientists, David Castellsen, Professor of Medicine at Stanford University, and James Hakim, a good friend of ours, Professor of Medicine at the University of Zimbabwe College of Health Sciences, who died from COVID-related complications. Dr. Castellsen made important contribution with his research focused on treatment and evaluation of HIV infection, including clinical trials to collect data on long-term impacts of adults living with HIV. Professor Hakim, on the other hand, served as an elected African representative on the RIAS Governing Council from 2016 to 2020 and dedicated his life to HIV research across antiretroviral therapy, prevention, opportunistic infections, and long-term complications of HIV. Professor Hakim has contributed to seminal HIV research with more than 150 publications and international communications, and was honored with the WorldScape Spirit Award in 2019 for his outstanding commitment and leadership to health, as a right, scientific and excellence and generosity in mentorship and support. It is with great sadness that we mourn the passing of these two phenomenal people. We will now take a short pause. Thank you. Now we will move on to housekeeping rules. So today's session, we will focus on PrEP. And this is our first session. This is what we are calling session 1, including sexual reproductive health for key and vulnerable population. A group work is also planned during this morning session and aims to build consensus on 3 key actionable items around PrEP to implement change: integration and development of HIV response at community, facility, government, and the South African region. We also have the RIAS Educational Fund team with us, and some of them are on the screen. Lauren Botting, please turn on your video and introduce yourself.
Yes, hello everyone. My name is Lauren Botti. I'm the Associate Project Manager for the RIAS Educational Fund. It's great to have you all here connected with us for this first session. I just wanted to introduce myself because I'll be here behind the scenes, so you might see my face, and I just wanted you to be able to recognize my voice as well. I'm also here with Laure Felix Bauer and Camilla Fontura. We're here as the RIAS Educational Fund team. So if you have any questions, please don't hesitate to reach out to us through the chat or also at riasedu@riassociety.org. For the moment, everyone is muted. However, we will have a second part of the session, which will be entirely around group work discussions. And this will be really important to have your input. And at that point in time, you will be able to unmute yourselves and we'll be able to have a large group discussion to try to reach the key aims that we have for this meeting and reach some key actionable items for the topics that we've chosen throughout this workshop. Right now, actually, to see if everyone can use the chat, I was wondering whether you could please introduce yourselves by just typing right below the screen. You should be able to see a box, and please type in your first name, last name, organization, and the country you're from, because I know that we have quite a few representatives from around the entire Southern Africa region here today with us. So it'd be great to see if you can use that chat function and also connect with each other. Then we also have a sort of separate chat feature, which is further down below your screen. And with that, you can connect on one-on-one calls, video calls, and meet anyone you'd like to meet that's online on the platform here today, you can also do this outside of session hours. So this hopefully will help you meet new people in a virtual world. I think this is rather important. The other thing I wanted to say is that we have the pleasure to announce that this workshop is entirely CME accredited. So the more you participate in all of our sessions, the more credits you can get. So hopefully you'll be able to participate in all 6 hours, because that would mean you'll get 6 credits in total. And if you're interested in getting these credits, please reach out to the RIAS Educational Fund team at iasedu@riassociety.org. And we'll be able to let you know a bit more about the information we'll need from your side to be able to provide those credits to you. And the last thing actually on my side for today is we want to know how you're feeling. So we're going to try to launch some polls, and we have 2 questions for you. So hopefully soon on your screen, you should be able to see a poll with the question, how are you feeling today? And then the second question will be, what are your expectations for today's session? So let's see if we can launch those, and let's have as many responses as we can, please, let's wake us up this morning. Great, so I see that there are results. So a lot of people are feeling great, which is fabulous, and excited. And I see 8% are curious. And I think, yeah, so you're not sleepy, you're not confused. It's fabulous. I think it's a great start. I think we can go ahead with the second poll, if possible. Great. So what are your expectations for today? We're trying to see if you can get a better understanding of HIV new developments, getting ideas and finding solutions for challenges you might face at work, getting new ideas on latest findings in HIV, gaining opportunities for collaboration, finding new strategies on how to improve HIV policy and programs, and gaining new contacts. Hopefully the chat features will be able to help you with that. Okay, so quite a variety actually. I see the highest is gaining a better understanding of HIV science and new developments for the moment. Okay, well, thank you very, very much for participating in this. And now, please continue, Professor Ngori.
Thank you. It's now my honor to introduce Dr. Danielle Traville. Dr. Traville is a research clinician at the University of Witwatersrand, South Africa. The title of Danielle's talk is Prep for All in Prevention, Sexual Reproductive Health for Key and Vulnerable Populations. Dr. Traville, the floor is yours. Please feel free to type in your questions as she presents, and we'll also have a Q&A session towards the end of her talk. Thank you.
Hi, my name is Danielle Traville. Good morning. Thank you for having me here today. Today I'll be chatting about PrEP for All in Prevention, Sexual Reproductive Health for Key and Vulnerable Populations. So there's an ongoing need for HIV prevention services, with about 1,300 new infections occurring among adolescent girls and young women alone in South Africa every week. This high incidence rate is paired with data showing us challenges in consistent condom usage and ongoing exposure from increased numbers of partners. Despite young women reporting pregnancy prevention as being incredibly important, there's still relatively low uptake of contraception and high rates of unintended pregnancies. We have limited population level data on STIs, and the majority of data that we do have comes from clinical trials and demonstration projects, which have shown really high rates of STIs in vulnerable populations accessing PrEP, majority of these infections being asymptomatic. Important to note that vulnerable populations have a 10 times increased rate of STIs as compared to the general population. So how do we address the sexual and reproductive needs of vulnerable populations? Firstly, we need a comprehensive package of services that adequately addresses sexual and reproductive health needs. And this may include HIV testing, hepatitis B screening, which is part of both PrEP services and ART services, urine pregnancy tests, TB, mental health and substance use screening, STI screening, and the current mainstay of treatment in South Africa, which is syndromic case management, syphilis RPR testing, risk reduction counseling, the provision of condoms, male, female, and lubricant if available, post-exposure prophylaxis, contraception, VMMC, and HRT. And then in addition, we introduce PrEP and referral as needed. And at the moment, PrEP is oral pre-exposure prophylaxis, and hopefully in the near future, we'll have mixed modalities that young women can choose between. But in addition to services being available, they need to be provided through acceptable and accessible service delivery models. And this includes non-judgmental services that are tailored to the individual's needs and are sensitive to the needs of vulnerable populations. They need to be appropriate in the way that they're delivered, and as well as being delivered at a time that's appropriate and in a space that's appropriate. And they need to be provided by trained healthcare workers. So the integration of services is important, and we often speak about integration, but what does that really mean? So integration refers to service delivery that is joining operational programs to ensure effective outcomes through many modalities, putting the comprehensive needs of people at the center and empowering them to have a more active role in their health. So this figure in this slide is from a DREAMS program in Kenya and just demonstrates that there's a range of models of integration. Typically, when we think of integration, we think of the one-stop shop, and this is one model of integration, but it's not the only model of integration. Other models include, for example, the supermarket model, where you have one building but different service providers providing different services that are relevant to sexual and reproductive health needs. And it's important to acknowledge that there are different ways to integrate services because not all models are feasible in all contexts. For example, on a mobile van, doing a pelvic exam may not be feasible due to the lack of privacy and the lack of space, and therefore you may need to refer someone into a fixed facility in order to do a pelvic exam. So having these levels of integration rely on good referral capabilities, good coordination, and having capacitated providers to offer patients all these services that they may need. The integration of HIV prevention and SRH services is not new, and there's a body of evidence that assesses the benefits and outcomes of integration. And the evidence shows us that the system is desirable for clients. It increases service uptake. It decreases stigma for assessing certain services. It improves the quality of care, and there's an efficient use of resources. It's also been shown to promote an understanding of protection of sexual and reproductive health rights. Providers largely approve of the integration of services, and they can see how this may benefit clients, reducing the number of consultations they have and making sure that they receive all the services that they need. Providers do, however, express concern around waiting times, workloads, and do express the need for further training. Users of integrated services approve of these services. They like getting all their services together and being able to build a rapport with healthcare workers. They say it reduces their clinic visits and the associated costs with it. And they like the providers and the service that they were providing, but they also express concern about the providers becoming overwhelmed and how this may affect their quality of care. So specifically family planning and HIV prevention, integration has been shown to be feasible and effective and can happen in a number of different ways. There have been a number of demonstration projects which have successfully integrated HIV prevention into family planning services. And they've done this through a range of provider models, including fixed facilities, mobile vans, one-stop shop, adolescent and youth-friendly services, even making use of digital platforms. However, healthcare workers needed capacity building and did require some job aids in order to support this integration. It's important to note that this integration can be bidirectional and both are effective. So integrating PrEP or HIV screening into family planning services increased the rate of PrEP uptake. So 22% of family planning clients accepted PrEP when offered in family planning clinics, and vice versa was also true. About a quarter of PrEP clients initiated a contraceptive method when starting PrEP. Another benefit of integration of family planning and HIV services is the alignment of the visits. You're getting people into the facility regularly within a year, and aligning these visits can be incredibly important. But in addition to that, exploratory analysis from the Jalinde program in Kenya suggested that continuation rates were better amongst adolescent girls and young women who were on both family planning and PrEP, as opposed to those on PrEP alone. So as mentioned before, the burden of STIs is high in this population, with the vast majority of these infections being asymptomatic. STIs have often been pushed to the side, but it's important to remember that STIs can have long-lasting sequelae for the individuals and also have a significant impact on public health. The mainstay of treatment for a long time has been syndromic management in South Africa, and a systematic review looking at data between 2000 and 2018 highlighted some of the limitations of syndromic management. 60% of vaginal discharge syndromes were overtreated, and 72% of treatable STI infections were missed as they were asymptomatic. This has an impact on antimicrobial stewardship, and therefore we are seeing an emergence of antimicrobial resistance, specifically with gonorrhea, and this is becoming a global concern. The expansion of PrEP programs has shone a light back onto STIs and provides us with an opportunity for integrating etiological testing into PrEP programs. So moving towards etiological testing is a good first step in key populations and can have a significant benefit for STI prevention and control. A DCE done by Saika Malik and her team showed that this is favorable towards young women. And when asked, they said that they would prefer to do self-collected swabs. They prefer to get the results on the same day and were prepared to wait 2 hours for results, and would prefer to access treatment from a non-clinic based venue. But it's important to remember that lab testing may not be a silver bullet. Yes, it does help identify asymptomatic infections and can help us treat infections more appropriately. But as you can see from the bottom data from the POWER project, about a third of young women were diagnosed with an STI, and we successfully brought about 2/3 of those young women back in for treatment. Those who returned had good pre-existing health-seeking behaviors, had good consistent condom usage, and were using contraception at enrollment. They were also more likely to return for treatment if they were seeking services at an adolescent dedicated facility. But the remaining third that we were unable to bring in is where we should really focus at the moment. And improving knowledge and possibly getting a near point of care test may mitigate this loss of return. It's also important to remember that integrating STI testing into PrEP services is mutually beneficial for both these services. Reducing STI rates in key populations who are accessing PrEP services is helpful, but in addition, offering HIV prevention to high-risk populations who may be presenting with STIs will also be beneficial. So just to summarize, we need to define and implement a standard integrated package of preventative services for STI, HIV, and pregnancy prevention, and relevant management services at all healthcare services. And it should ideally be embedded within services that are appropriate, for example, the youth zone for young people. We need to make sure that we have trained providers, and we need to develop job aids and tools to properly integrate PrEP and SRH services bidirectionally. And this shouldn't be hard to do because we have such great materials for each of these programs individually. We need to innovate, implement, and evaluate decentralized, simplified, and self-care models that can further improve access for a range of services. We should link all STI clients to PrEP. We need to strengthen existing STI services. So do this through training, making sure we have adequate commodity supplies, having good information materials, having adequate space and facilities to provide these services, and make sure that we're collecting good data for monitoring and indicators for the integration of services. And lastly, we should be generating data on impact, cost effectiveness, feasibility, and acceptability of STI screening in PrEP services, and demonstrate feasibility and acceptability to clients and providers, but also estimate impact and cost benefit. Thank you very much. I'd just like to thank Sinead Delaney Moretwe and Saika Malik for their input on these slides. Thank you.
Thank you, Dr. Travel. We are now open for questions. And please feel free to type in your questions. I have probably missing some that have been typed. In the interim, maybe Dr. Travel, you could probably tell us whether point of care etiological testing is available in South Africa. Is it for STIs? Because that would be key.
Thank you so much. Good morning, everybody, and thank you so much for having me here today. So at the moment, we don't really have a point of care test yet for chlamydia and gonorrhea. Our turnaround times typically are about 24 hours. Many clinics are fitted with a gene expert machine, and gene expert machines can run tests and can do so within 2 hours, but implementing this has been challenging in primary healthcare setting. And so although if needed, we can run a test probably in about 2 to 4 hours. Typically, the turnaround time often takes about 24 hours as the samples go to lab tests. So hopefully moving forward, we can reduce these times. And if we can implement using the Gene Expert platform that was implemented in primary healthcare clinics for TB care, if we can use that platform for testing for chlamydia and gonorrhea, that can expedite turnaround times, particularly for chlamydia and gonorrhea.
All right, thank you. It's a great presentation.
Thank you.
Any other questions? I'd probably invite Professor Rita Gell to make some comments on that presentation.
Yes. Hi, Kenneth, happy to do that. So Danielle, I do think I know in that DCE there was a question around whether adolescents would wait. And I've heard the etiological diagnosis described as a near point of care because it does need that 90-minute wait. What are your thoughts about whether young people will stick around for the diagnosis, or do we think it will still be a come back tomorrow kind of integrated service?
So the DCE results suggested that young women were happy to wait about 2 hours for a result, but anything longer than that, they preferred to come back a different day for results. And I think that that's definitely been our experience. I think that people are typically used to spending about 2 hours in a primary healthcare clinic, probably 2 to 3 hours in a primary healthcare clinic. So that's not unexpected, and would be willing to wait that period if the turnaround time could be that quick. The challenge with, and kind of, I guess, the benefit that syndromic management has over etiological testing is that you don't lose anyone. Everyone's kind of there, you treat them, and then you don't need to worry about them coming back to the clinic. The challenge that we've had in demonstration projects or screening programs that we've done, where we've done gene expert urine testing on young women and on some men, was the challenges. There are two challenges. The one is contacting people after they've left, and getting reliable contact information is a lot more challenging than one would expect. And even those that we do manage to contact, there's still a challenge in bringing them back to the facility if they don't have another reason, for example, like a family planning appointment or a PrEP appointment or an ART appointment. And so I think if we could get a near point of care, a 2-hour program that someone comes in and you run the test while they're at the facility, I think that would be preferable. And there's some thought into trying to reduce that time of running the test, which would be wonderful if that was feasible. Alternatively, I think trying to sync that with other visits, which is why the integration into PrEP services is so appealing, because these are people that are traditionally, hopefully, going to be coming back to the facility for other services anyway.
Thanks.
Thank you. So I don't see another question. I think we can move on to the next step, which is then to take a short break for about 5 minutes. And then you'll find a link provided in your chat box, which will allow you to click and connect to your breakout rooms after the short break.
Yes, if you could please try to connect, and then once you're in the Zoom account, you can take a drink or go have a mini break, just in order to make sure that you're all connected. So we'll see you there.
Yep.
Thank you, everyone.